Of course, in our discussion of sexual health, we're going to have our STIs come up quite a bit. We'll keep seeing STIs a couple of different times. We'll see some of our STIs under our skin lecture during week 10 as well. So gonococcal urethritis is caused by a diplococcus known as Neisseria gonorrhoeae. It's a great word. It is. It's sexually transmitted. There could be no symptoms at all with this. Some people will have it and have no idea. But in some cases, there can be a urethral discharge and a drip, burning with urination. And potentially, if it goes untreated, there could be urethral strictures, abscesses, and fistulas could form as a result of that. Moving on to disorders of the scrotum and testes. If you have the male anatomy, there's going to be some wincy stuff coming up for you, just to warn you. Congenital, acquired, infectious, and neoplastic. Hydrocele is going to be an accumulation of fluid within the scrotum, so surrounding the testicle or spermatic cord. Usually this would occur after a scrotal injury or potentially after radiation therapy or infection of the epididymis. If it's painful, then it can be surgically drained. It does tend to accumulate over the span of a day. It's going to, with gravity and walking up and about, that's going to accumulate. What's that? Kind of. I mean, a bursitis, you have that synovial fluid space specifically. So you have the synovium that's specifically secreting a serous fluid, whereas it's not really normal to have this fluid accumulation in this space. What's that? With liver failure, ascites is going to happen with liver failure, and it's going to fill up the peritoneal cavity quite a bit. I imagine you could see this in association with ascites. One thing that happens with male anatomy is the descent of the testes leads a continuation between the peritoneal cavity through the inguinal canal into the scrotal cavity. So if you have experience, if you've seen that with hydrocele in association with ascites, I wouldn't be surprised by that. Spermatocele is going to be similar, except that cystic mass contains sperm. We don't really know why that would happen. It is poorly understood. Just sperm. Yeah. Why? We don't know. Again, this would typically be a painless mass. Another cringy one coming up. You already see it? Okay. Testicular torsion. This is more likely to happen in prepubertal males. This is going to be an immature spermatocord that has more flexibility, is less anchored, and so mostly related to an injury. It's simply the spermatic cords twist around each other within the scrotal sac. Yeah. Yeah, you've got to just reverse the twist. The issue is what's in the spermatic cord. Think about some structures that are part of that spermatic cord. Blood flow. You got your arteries, your veins, your nerves are in there. Yeah, and of course the spermatic cord, the vas deferens is in there as well. So there's going to be quite a bit of compromise. The idea is we get it treated very quickly to avoid ischemia and damage to the testicles.
Why does it usually happen?
Again, it's because of the flexibility in the prepubertal male, and it's probably going to be a response to an injury in all likelihood. It's probably not that likely to happen spontaneously, at least not to that severity spontaneously.
My
Just
sister
stop.
had torsion of her ovaries,
Mm-hmm.
and they kept putting it off. And they kept telling her that she was having, like, they were like, you need to see a GI doctor. Like, that pain isn't got anything to do with her reproduction. And it got so bad that my mom finally took her to a different hospital, and they rushed her into emergency surgery because her ovary had torsion so bad that it was necrosing.
Yeah.
And they were like, had she gone
So was it just undiagnosed before, or did they? Okay.
Well, and then
So they were just saying, okay, you've got abdominal pain. Who cares?
Yeah.
Deal with it. Yeah.
They were like, nothing's working. Like,
Right.
it's not normal. It necrosed. Like, they were like, had she gone to sleep, it would have killed her. Like, she would not have been alive. Like,
Absolutely. So yeah, ovarian torsion.
Because of it.
That's unfortunate. I'm sorry to hear that. There is a long tradition of ignoring female pain in medicine.
Oh my goodness.
Very, very long, lengthy tradition of ignoring female pain. Right. Yeah, there's a great video to that effect if anybody wants to watch it later. But I'm glad that she got it. She got a second opinion and got that treated.
Yeah, she has to be careful because like her ovaries were like maybe a little larger. And so her other one, it like she can tell when it starts to torch, and so they have to like go in and like kind of like readjust her to like
Interesting.
get it to normal. But yeah, she has to do it forever.
Interesting. So there's maybe a congenital anomaly
Yeah, it's
that
like
she makes her
it's
prone to
like
it.
her ovaries are kind of almost like floating, like they're
Okay.
not really
Yeah, you
anchored.
should have suspensory ligaments that should prevent that from happening. Again, much like this, if there's greater flexibility than there should be in those suspensory ligaments, that would make her more prone to that as well. It's pretty intense. Back in the male reproductive system, males have prostate. Females technically don't have a prostate. We actually do have analogous tissue. We have some vestibular glands near the opening of the vaginal orifice. That we are starting to determine is very similar to a prostate. However, women do not typically have or technically have a prostate. So men are going to develop benign prostatic hypertrophy. And when I say men are going to develop benign prostatic hypertrophy, I mean 80% of men over the age of 60. And another way to phrase that is if a male gets old enough, he's going to develop BPH. Yeah, it's just unbelievably common. I think I mentioned this during our prostate cancer. You've already seen this prostate cancer slide during our cancer discussion. I mentioned how benign prostatic hypertrophy is more likely to develop central within the prostatic, just immediately surrounding the prostatic urethra, whereas prostate cancer is going to be more likely to develop in the periphery of the prostate gland. So BPH is more likely to very quickly cause problems with urination. Yeah.
So on here it's benign prostatic hypertrophy and benign prostatic hyperplasia.
Yeah, I think hyperplasia is a better term for this one. It is going to be cell size and number. Hyperplasia is probably. Technically no, but for the purposes of this, yes. Technically, hypertrophy is just by size. Hyperplasia is by number. I'm going to argue this one is better for hyperplasia. Which one? That one? So I think this is actually showing you, let's see, yes, this is showing you some enlarged hyperplasia of this tissue.
Isn't it super hard to like catheter around?
Probably. Yeah, I wouldn't know, but I imagine so. So there's a special tool that you would use to catheterize somebody with BPH?
Yeah.
That makes sense. I think any large enlargement would be considered BPH, as I understand it, unless there's some other mass that's not related to prostate tissue. I've never heard of anything else. I could be wrong. I don't know every disease out there. I know the ones I teach. Yeah, right. Well, this would not cause hematuria necessarily. There's no reason for BPH to cause hematuria. It's going to cause problems urinating. It's going to limit urination. There's going to be urinary urgency. There's going to be a lot of urinary stasis within the urinary bladder. So on ultrasound, the bladder is going to be very, very full even after they micturate. They're going to try to pee. There's just not going to be a lot of it. And they're always going to feel like they have to pee. They're going to go back to pee again. A little bit of pee is going to trickle out. There's lots of medications for it, but none of them are perfect. Yeah. I want to say vestibular bulb. There's another name for it that's a lot fancier that I don't remember. I think so. Bartholin's glands. That sounds right. I should know this, but I don't. Okay, so again, unbelievably common BPH. Really scary because that differential is between BPH and prostate cancer, right? But again, with prostate cancer, it's happening in the periphery. By the time prostate cancer causes problems with urination, it's pretty advanced at that point. Okay, female genital and reproductive function. Our first one is going to be uterine prolapse. If if you're genetically female and have female biology, then there's going to be some cringy pictures from you now. For you now, congratulations. So bringing up those suspensory ligaments of the uterus, right? Typically, women are going to have the structures of the uterus, the uterine tubes, the ovaries suspended within the pelvic cavity. And that's the normal status. A number of things can cause problems with those suspensory ligaments. Some of it could be congenital, as is probably the case in that what we were just hearing about. But pregnancy would also be something that would stretch out those suspensory ligaments, and that would make something like uterine prolapse a lot more likely to occur. So uterine prolapse means there's a problem with the suspensory ligaments such that the cervix is going to collapse through the vagina and by degrees potentially even exit the vaginal opening into the external environment. So it's by degrees. There's a first degree prolapse. The cervix is still within the vagina, but it's not set as high as it should be. Second degree prolapse, the cervix and cervical os can be viewed through the vaginal orifice. And a third degree prolapse is what's on the next page. To me, it just looks dry and itchy. I'm sure you've got way worse pictures than this. Oh, 100%. Yeah.
It looks like one of those stress balls.
Like a stress ball.
Oh my gosh. That's what it looks like. It's like
moving on. Now, the good news here is there aren't actually a ton of nerve endings. There aren't a ton of somatic nerve endings. This is visceral innervation at this point. We've got some stretch receptors as females here, and not much else. So I've heard stories, I've never experienced this firsthand, but I've heard stories from students about, yeah, we had a patient who had uterine prolapse. She was just pushing it back in and going about her day. Yeah. Yeah. So they're overstretched. So they've got laxity. Right? Instead of holding things up, they're collapsing down.
Like, yeah, sometimes my wife's uterus just pops out and I just help her put it back in. We were all just scarred.
That's not something to tell high school students, probably.
It was weird.
It's maybe not appropriate. Yeah, let's move on. Okay, fun fact, everybody has a tilted uterus who has a uterus. All uteruses are tilted. The question is, which way is that uterus tilted? And that's a different concept from a flexed uterus. So most uteruses will be sort of mid-position. They'll have a little bit of an anterior displacement, but there can be anteversion where it's has very anterior displacement. There can also be retroversion where it has a posterior displacement. And then when it becomes flexed, it's a little bit more serious. So for things like retroversion, there's a mild effect on fertility. Like implantation, circulation to a developing embryo may be slightly compromised. If you know that you have a retroverted uterus and you want a pregnancy to succeed, there are steps that you can take that are very, very simple to negate the effects on fertility for those things. Flexion is a little bit more serious. Yeah.
So let's say like I have a uterus with like in a certain position. Is that always going to be in that position? Like, is it held there? Or let's say like in a year, it could be in a different position.
So generally this would be consistent during pregnancy. The thing is that the uterus is going to grow. So as I understand it, and I'm by no means an expert in this, there would be positions that you would take during your pregnancy to encourage the uterus to develop in a certain direction. Yeah. I mean, after pregnancy, you're going to have changes to the suspensory ligaments probably. So I'm not entirely sure. So 20 to 30% of women are going to have some kind of retro displacement of the uterus. It's going to be very common, but could be present through a woman's life or develop after childbirth, which is why I answered it that way, is after childbirth, things can definitely change. All right, PID. Here's another upsetting one. This one's going to be unique to women. Men are, in all likelihood, not going to develop PID unless there's some other abnormality going on. Now, I got kind of gross about this in AMP2 for a specific reason. We mentioned how our peritoneal cavities are open to the environment. Remember that gross story? How you could hypothetically stick a wire through all of this and end up in the peritoneal cavity. Sorry to bring up the wire. I know it's an unpleasant thought. That's going to be the source of PID. It's going to be an ascending infection from the external environment through the vagina, through the cervical os, through the uterus, uterine tubes. And then once you get to that ampulla of the uterine tube, you've got a clear space out to the peritoneal cavity. The only thing between women's peritoneal cavities and the environment is some mucus, basically. So things like gonorrhea and chlamydia, they can infect men or women, but women, because we're open to the environment, have the potential for that to develop into PID. Pelvic inflammatory disease is when that infection makes it into the peritoneal cavity and infects peritoneal structures. That's going to go with abdominopelvic pain, and it's potentially also caused by surgeries. Probably not from an IUD insertion unless they did something wrong and it was contaminated. I feel like that's a little biased. There's some scare tactics around IUDs because of some sketchy history we had in the 1980s. You guys want to hear about that? You look like you want to hear about it. Okay, if you've got an IUD, you're fine. I promise. Let me show you IUD shield. Dalkin. All right. Yeah, it's the dentist office right there. Let me show you an IUD that was definitely not invented by a woman. That's an IUD from the 1980s.
Nope.
No, the caption that's in the uterus. Yes. Okay. So it was definitely a man who invented this buzzsaw that is supposed to go in your uterus. There were multiple problems with this. Obviously, one of them is that it's basically a buzzsaw for your uterus. The weird part about this is the thing that was actually causing infections is that the string was a string. These days, not wire, not plastic, string. It was very dumb. Okay, so in the 1980s, the FDA approved this. A bunch of women got it. Not listening to women is how I got through the FDA. Okay, a bunch of women got these. A lot of women experienced intrauterine infections, infertility, uterine rupture, all kinds of fun stuff. And so for a long time, there were a ton of scare tactics around IUDs. A lot of women just said, no IUDs. And of course, modern IUDs do not look like this. They are not like this. So modern... There's the modern IUD. It's going to have a biocompatible sort of string, plastic, metal. It's slim, it's flexible. There's hormonal forms and non-hormonal forms. Our rate of infection for this is very, very low. Our rate of uterine perforation is very, very low for these. I mean, IUDs have had a number of shapes over the years. Let me show you some different IUD shapes. People have tried to get really creative about what you stick in your uterus over the years. Do you guys know the origin of the IUD? It's kind of weird. Probably, yeah. Camels. Camels crossing the desert. We don't want them to get pregnant, so we put rocks in their uterus. Yeah. Yeah, using elephant dung. Yeah, birth control is a rabbit hole subject. We could go on that forever. Okay, so that's why it's honestly, we probably in modern times do not need to worry about insertion of intrauterine devices, but it kind of persists in a lot of textbooks and a lot of resources because it was so bad back then. We still have some biases about it. We're still counseling women, don't get an IUD unless you've already had a baby. You want your uterus to be a little bit bigger. Like, no, you can have an IUD without a prior pregnancy. It's fine.
When I got my baby, before they still believed that.
Yep.
And, like, it was not something that you should get until you have a baby.
Right.
I mean, I've had mine for 10 years, but it's like, I was 17 when I got mine. Yeah, see, my mom said, get this or don't have a boyfriend.
Okay.
That's one way to do it, yeah. Yeah, overall, modern IUDs are fantastic, and they have the best pregnancy prevention rate of any birth control form. And most healthcare professionals opt for IUDs knowing all of these facts, and it is the least regretted form of birth control. Yeah. Okay, so PID, let's see, there's our ascending infection pathway for PID, just showing you that continuation. You could also have strep and staph that could cause an PID. Abdominal tenderness, pelvic pain, cervical pain, fever, elevated white blood cell count, and vaginal discharge. Potentially, the issue here is PID can lead to infertility.
Isn't this another one that they were kind of saying that when we're blowing out a proportion and it takes a long time to actually get diagnosed?
Probably. Oh, you mean one of those things we didn't listen to women about? Probably, yeah. They all are. Anything involving women. I mean, there's so many things, like endometriosis, for example. We know so little about it. So little. So many female-associated conditions that we just don't know anything about because the research dollars just aren't there because it's male-dominated. And yeah, no, it's a real issue. It's not me being biased. These are facts. I can document this. Citation needed? I got it. I got your citations right here. I'm sure I'll be able to think of 5 other female-dominated things that we know nothing about. Oh, eclampsia, preeclampsia, eclampsia. We know nothing about it.
That's fun.
Nothing. We have some suspicions about endothelial disorders, and that's where we're at with eclampsia. Yeah. It would be an intensely interesting thing to do the paper on. I would make sure you're a good writer so that you can anticipate the challenges for writing about something that we know very little. There is some new evidence coming out that's really interesting. It's taking an interesting direction. I chatted with some people at the anatomical conference about it, looking into restoring endothelial function to treat preeclampsia as a possibility. Yeah. Okay, let's talk about endometriosis. We've mentioned this before during our respiratory lecture, in the sense that we can have ectopic endometrial tissue that makes it into the thoracic cavity. More likely, our ectopic endometrial tissue is going to be within that peritoneal cavity or the pelvic cavity and be an immediate surrounding area. It can go to the ovary, the peritoneum, the oviduct, the outer layer of the uterus, the bladder, the intestine. There's actually a couple of competing, not exactly competing, maybe coexisting hypotheses about endometriosis. One of them is really, really simple and straightforward. One of them is the school of thought that during normal menstruation, because all of these structures are open, some of that menstrual product simply goes into the peritoneal cavity instead of exiting through the cervical os and vagina. And that would just be a really straightforward way to get endometrial tissue in an ectopic site. That endometrial tissue that would otherwise be shed and discarded is now finding a rich vascular supply in the mesenteries, right? So it's able to sustain itself. That's a really straightforward way. The other would be about, if I recall correctly, I want to say stem cell migration. Stem cells associated with the endometrium end up in ectopic sites for whatever reason. That one seems a little less straightforward. Occam's razor, I'm going to go with the first one, but it could be both. It could be either. And again, it's very poorly understood why some people are going to have extreme pain as their experience with endometriosis, and some people are going to have very little. It seems to only be somewhat correlated with the degree of endometriosis and the degree of ectopic sites of implantation. Cervical cancer, mostly caused by the human papillomavirus. There are many different mutations of HPV. Only certain types are going to cause cervical cancer. And of course, this is what we detect with pap smears. When we're doing a pap smear, we're looking for healthy, normal epithelial cells. Cervical dysplasia is when we see disorganized growth of an atypical growth of the cells of the cervix. Now, I do want to clarify, because your textbook is slut shaming again, that 80% of the sexually active population is going to be exposed to HPV. So everybody's got HPV or has had HPV or will have HPV. It is going down. The vaccine, that's a great point. Thank you for bringing that up. The vaccine has already cut new cervical cancer cases in half. Yeah. A few years. Yeah. Yeah. So vaccinate your kids, even if you don't like the thought of your kids having sex. They probably will at some point. Vaccinate your kids.
Yeah, they are like scared about it. These boys, and they're like, oh, I want to get my son. And yes, you do.
Yes, sons should get it too. Sons and daughters. Human papillomavirus can infect the vocal cords too. Can infect the larynx. Matthew Douglas had throat cancer from it. Yeah. So I mentioned some preeclampsia. Pregnancy-induced hypertension, toxemia, preeclampsia, and eclampsia, like I said, very poorly understood. Leading cause of pregnancy-related deaths. Look at this completely useless statistic. Anywhere from 0.5 to 10% of pregnancies are impacted by pregnancy-induced hypertension. It's basically, we have no idea when you see a number like that. Characterized by a very rapid rise in arterial blood pressure. And also, you'll be able to test proteinuria on this one. I don't know. Magnesium for preeclampsia. No. Good pharmacology question. So there's a correlation. I don't know if we've got causation. It's speculative to give them magnesium. Yeah. Okay. Yeah. I mean, I imagine it has something to do with neuromuscular excitability, like we talked about with our electrolyte imbalances last week. But I can't see a good reason for it. Like I mentioned, there's people doing cutting-edge research on endothelial function. Part of it has to do with placental circulation, we think, as well. Part of it's going to be like the stress of the fetus during, if there's compromised placental circulation. That's where the schools of thought are, but it's pretty complicated, yeah. To prevent seizures, okay. So extra magnesium means more bodyguards, means less neuromuscular excitability. Yeah. And do it. I like it. Thanks for going on that trip with me. That was a good one. Here's a really great naming convention. I really just like what this is called. Hyperemesis gravidarium. Who wants to translate? Excessive vomiting during pregnancy, or literally, lots of vomit pregnant. That's great. Yep. I felt like all the visuals we've been getting today, we kind of needed a break. Yeah. You're welcome. There's some more gross ones coming, don't worry. Now, this is a little bit more severe, a lot more severe than simple morning sickness. Both of them, we assume, are related to a sensitivity to human chorionic gonadotropin, which is a hormone released by the implanted embryo, if I'm getting that correctly, early on in pregnancy. So, yeah, I mean, it's normal to have some response to HCG in the form of nausea, but hyperemesis gravidarium is an extreme sensitivity to that thing, as far as we know. The issue here is that the vomiting is so severe that you're going to end up with electrolyte imbalances and acid-base imbalances. So much so that you can end up with liver and kidney damage. Yeah. I have had a student who said they've experienced hyperemesis gravidarium. They made it. They're alive. Yeah, hospitalization. We've talked about breast cancer before. We talked about how it's most likely to come from either ductal cells, ductal carcinomas, or not the duct, the glandular cells. Let's see. Males can get breast cancer as well. It's just 100 times less common. And our recommendations change all of the time. So honestly, a textbook that is a year old is probably already recommending the wrong thing in terms of mammography. So I would ignore that entirely. Risk factors for breast cancer, there's actually a lot of them. Some things are increasing risk of breast cancer, some things are decreasing risk of breast cancer. They've shoved them all kind of together. Oddly enough, giving birth before the age of 18 decreases chances, as will having more children actually decreases the risk of breast cancer. It's both BRCA genes, yeah. I want to clarify, childbirth also increases the risk of other things, including other cancers. So there's no motivation here to have more children or have children at a younger age, just to avoid breast cancer. Giving birth after the age of 35 years of age increases risk of breast cancer. Low parity means fewer children risks more breast cancer. Breastfeeding also seems to decrease, and our understanding of that, again, is very poor. We're thinking maybe those mutated cells are being sloughed through the process of breastfeeding, and baby's digesting it. It's not like you're going to get cancer from that, the baby. So it's all good. If your mother or sister has had breast cancer, that greatly increases your chance of developing breast cancer. If you possess the BRCA1 or BRCA2 gene, those are also a sign of potential breast cancer and ovarian cancer. And again, the genes, it's going to be complicated. You need the genes, and you may or may not develop it based on possessing those genes. And of course, that's pretty controversial, right? The genetic testing, who's going to find out if they have BRCA1, BRCA2? How extremely are you going to respond to having the BRCA1, BRCA2? Are you going to do a double mastectomy, have your ovaries removed in response to having those genes? Or are you going to take a wait-and-see approach? And there's a ton of controversy around it. There's celebrities getting involved. Angelina Jolie famously did her double mastectomy.
Even on like the 23andMe, because it tells you like genetic stuff, I had to click like 4 different things for it to let me see the BRCA genes. Like if I carried them, it's like, are you sure? Are you like so many roadblocks of if you're not emotionally able to handle it, do not look. Yeah.
Yeah. Not to mention all the problems with those genetic testing services to begin with. So sketchy. Okay. Again, cancer of the breast coming from either the epithelium of the glandular ducts or from the glands themselves. Glands or ducts. 2/3 of them are going to be in the lateral portion of the breast tissue. Okay. What else did I want to say about this? We worry about it disseminating into nearby lymph nodes, most likely the axillary lymph nodes or subclavian lymph nodes or infraclavicular lymph nodes. Let's see what else do I want. Do you guys know the concept of the sentinel lymph node? I think it's a really cool idea. So if you had a tumor, let's say your tumor was right here, we could inject it with sort of dye that's going to be detectable radiologically and also visibly. And that lymphatic drainage is going to take that dye in a very specific direction. So then when we're doing surgery to remove lymph nodes, we can see where that dye is the thickest. And that's actually also going to give us the most likely route of metastasis from breast cancer. So that's right. It's a really big problem of how many lymph nodes do we remove to be safe. Because we want to get rid of every single cancer cell in order to successfully get rid of cancer. But what happens if we remove all of the lymph nodes just to be safe? Yeah, so you're going to have lymphedema as a result. So you're going to be compromising your lymphatic drainage pathways from your arms. And that's going to be a lifelong consequence. That doesn't happen, right? Yeah, absolutely. Yeah, that would be lymph node removal. Yeah, there's actually a field of massage therapy called lymphatic drainage that's gaining in acknowledgement in the medical community. Some of the underlying premises is pausing. Mm-hmm. Yeah, TED hose. So there's going to be limitations to what the TED hose can accomplish, but yeah, that's the idea. Is we got to get it to drain out, but it's going to be a long process, and it has to be a process. Let's see. Now, just to remind you that with breast cancer, it's not always necessarily a lump. I actually really like this image right here as a PSA because it's showing you that sometimes it can be a divot, sometimes it's abnormal coloration or discharge. Sometimes some people may have a duplication of a nipple, for example, or an inverted nipple, and it's just good visual, right?
It is. It's crazy.
So any changes to the breast tissue are really what we should be advising people to be monitoring.
Is it harder to detect lumps and stuff like that if people have like more fibrous breasts than others?
Yes, and that's actually, I think there was a recent article about that, how we're sort of changing recommendations for people with extra dense breast tissue and some of the controversies that are popping up because of that. Yes, there are different textures for breast tissue that do complicate diagnosis.
Right, because there'd be some that would be hard to tell, like if that was just you or if that was something new.
Mm-hmm. Yeah, I heard of an MD who shall remain nameless. Honestly, I don't remember anyway, so it's not a big deal. But on my friend's clinical rotation, in his MD program, he worked in his OB rotation with a doctor who just seemed to be sick of it. Like she couldn't deal with it anymore. A woman came in with a lump in her breast, and to her face, this MD was very professional. As soon as she got out to the door, she turned to my friend and said, "Ugh, it's just a lump. What is she?" So yeah, he told me the story, and it was absolutely appalling. It's time to quit when you think
Really, yeah,
that.
go into something else then.
Yeah, time to quit, guys. When you don't care. Okay, moving on. Putting things that'll get me sued for libel on my recordings for YouTube. I didn't say any names, it's true. As I mentioned before, STIs, they're popping up multiple times. We've already seen gonorrhea and chlamydia. We'll see a few more with some absolutely upsetting visuals, don't worry. We've already also addressed HIV during our immunological discussions too. Most prevalent, 15 to 25 years of age. Some can be contracted non-sexually. Some things can be through mother to infant during childbirth contact. Occam's razor, most of it's going to be sexually transmitted. Pathogens transmitted can be bacterial, fungal, viral, or protozoan. And by no means are we covering every STI. I mean, not that we're covering everything for anything, really. I'm leaving so much out, and yet I'm covering so much. So gonorrhea, we've already sort of seen under urethritis. Can also cause cervicitis, salpingitis. Again, complication of PID. And it's again caused by Neisseria gonorrhoeae. Non-gonococcal infection would be caused by our good friend Chlamydia trachomatis. This can also result in PID. Potentially, this one can lead to infertility. I think that should be ectopic pregnancy right there, by the way. When you have some scar tissue along that uterine tube, remember that's supposed to be a ciliated epithelium in order to usher a fertilized egg towards the uterus. When you have scar tissue in those uterine tubes, then a fertilized egg may remain in the uterine tubes. Syphilis before antibiotics used to be the big killer. There are multiple stages to syphilis infection. It's caused by a spirochete called Treponema pallidum. And again, we're going to go ahead and shame men who have sex with men again. You do not have to be a man who has sex with men to be at risk for syphilis contraction. It can be anybody. Absolutely, yes. There can be in the tertiary stages of syphilis. There can be a potential for neurological and cardiovascular complications, as well as, like you said, some other tissues like your nasal septum can degrade. That's what's happening in this painting by Rembrandt. This is a rich guy who could afford to have his painting done by Rembrandt, and he has saddle nose. So part of the tissue of his face is degraded so much so that his nose is sunk into his face. Yeah. So initial infection, there may be just a very, usually a canker. It should be on here somewhere, maybe not. So yeah, canker at the site of infection. There may be some regional lymphadenopathy. You may not feel great. But then it's going to have a bunch of latent periods. So ultimately, you may end up with a disseminated rash and generalized lymphadenopathy. But then you'll have an extended latent period, years in which it's completely asymptomatic. Maybe there's no further complications. Maybe it's just a latent infection. Or maybe it develops into tertiary syphilis, in which you have neurological and cardiovascular complications.
And a lot of people miss the cankers because they're things that you don't want to see.
Right. Yeah, if you're not self-assessing, if you're not holding up a mirror and checking things out, you may not notice. We do have antibiotics that can treat this at this point, so that's the good news. Again, this used to be potentially a death sentence for people. HSV1, HSV2, we'll see these again during rashes. These are herpes simplex virus infections. HSV1 is typically associated with above the belt lesions. I'm doing air quotes. Cold sores or cankers associated with the oral epithelium, whereas HSV2 is generally considered below the belt. Genital herpes, most would be genital, anal, and perianal. That having been said, you can contract either type of virus on either epithelium, potentially. And your textbook likes some scare tactics, so here's another disturbing image of HSV2 type lesions on female and then male. And even on the male, you can tell it's some small red bumps. This one is a little bit scarier looking, and I think a little bit less common visually than that. One of the more upsetting pictures is coming up to tell you about cankroid. It's ulcerative, it's infectious. Did you look forward?
So bad, so bad, it's so bad.
We'll look at it very quickly. Obviously, if you have a canker on your genitals, that's going to make transmission of HIV that much easier. It's going to be an interrupted epithelium that makes other infectious agents, gives them a nice big opening, right? We're going to look at this real quick, and then we're going to stop. Okay. Again, sometimes I think your textbook chooses some scare tactic pictures, some things that show you the extremes of certain disease. I imagine not everybody with cankroid is going to have a canker of that size. I don't really know. I've never seen cankroid in real life, knock on wood. So let's keep that going, right? Molluscum contagiosum is a viral skin disease, part of the pox virus family. It's a milder than smallpox or chickenpox manifestation. It actually doesn't necessarily need to be sexually transmitted. It can actually be transmitted via skin-to-skin contact in children, for example. It is highly contagious, and it just looks like that. We've already talked about HPV and how that can lead to cervical cancer. Other forms of mutated virus can lead to some good old-fashioned genital warts. Good old-fashioned. Some non-sexual transmission has been documented. That virus can also be latent for long periods of time, too. And let's see, period of communicability is unknown. We don't know if you have to actively have warts that are shedding virus in order to communicate the virus. Probably you do. And we're just talking about the little bumps over here. Not these guys. That's not the same. And that's it.
Before lunch. Hey guys, go to lunch now.
Enjoy your lunches.